Thank you for a nice introduction. And I would like to thank BDMS and Dr. Somrit, the hospital director of Bangkok Hospital Phuket, and Dr. Art for having me here. And for today's topic in my talk, I'm gonna tell you about how do I evaluate polyp and the possible factor that may affect my evaluation of polyp. I start with definition first because I've seen a lot of people use advanced polyp like an umbrella term to cover malignant polyp, but in fact advanced polyp mean the pre-malignant polyp, which include adenoma with high-grade dysplasia or with intramucosal carcinoma, SSP with cytologic dysplasia with or without intramucosal carcinoma, and large adenoma or SSP, and any adenoma with villus component would be advanced polyp too. And some people include hypoplastic polyp, which is large in this advanced polyp, believing that this could be SSP that was misclassified by pathologists as a hypoplastic polyp, which is a reasonable thought, and I'll tell you later why. And for high-grade dysplasia and intramucosal carcinoma, in lower GI, it means the same thing in terms of biology and clinical management, but pathologists still reserve some kind of intramucosal carcinoma word for two reasons. First reason is because there is a distinct different morphologic difference between high-grade dysplasia and intramucosal carcinoma, which I'll show you later. And for the second reason, that why I still use intramucosal carcinoma, just to meet myself and my team not to confuse this pattern with true invasive carcinoma. And for the fact that there is no lymphatic in lower GI in mucosal layer, so high-grade dysplasia and intramucosal carcinoma has a zero risk of nodal metastasis, given the fact that you don't meet early submucosal invasion. And for malignant polyp, that would consist of polyp that has carcinoma invasion through submucosa into through muscularis mucosae. And some people may include the polypoid malignant tumor like neuroendocrine tumor or polypoid GIST, malignant melanoma or lymphoma. But for most of the time, everyday polyp is epithelial polyp. And this is the place for advanced polyp and malignant polyp in WHO classification. And for reporting element in pathology report, when I have polyp, I would look for advanced feature first. And if it's advanced polyp, I look for submucosal invasion. And then I measure the distance the distance from dysplasia to margin and give you a type of polyp and other feature that I can tell. But if it's a malignant polyp, I would go through every prognostic factor like the usual report of adenocarcinoma of GI with plus the type of tubular type of polyp that has cancer arising in. And this is the morphology comparison between adenomatous dysplasia and serrated lesion. When you have dark blue pencilated lack of mucin in polyp, it would be adenoma. If you have sawtooth-shaped gland with a lot of mucin, that would be serrated lesion. For adenoma, I would look for villus architecture and grading cytologic dysplasia. For serrated lesion, I would look at the crypt base. If it's narrow, it would be hypoplastic polyp. If it's broad bed like this one, it would be SSP. And if it looked pink with ectopic crypt, it would be traditional serrated adenoma, and I would look for the cytologic dysplasia in serrated lesion. And this is a spectrum from low-grade to high-grade dysplasia in APC pathway. And for serrated lesion, cytologic dysplasia would have the similar morphology to adenomatous dysplasia. Let's come to the factor that may affect evaluation of polyp before your submission of the specimen into the lab. The first factor that is important is endoscopic finding. As you may see in the case example, I saw 5 fragments of SSP in the slide and 2 fragments of adenoma. My question is, how many polyp did you see? Because if these fragments come from one single polyp, it could be SSP with cytologic dysplasia, which is at one polyp. But if it comes from 2 or more polyps, it could be just a decent fragment of tubular adenoma and fragment of SSP. Another example case that shows the importance of endoscopic finding. This is advanced polyp under endoscopy, and biopsy from polyp head confirmed the presence of high-grade dysplasia and intramucosal carcinoma. But there is a separate container of colonic mucosa that show slightly serrated surface with broad-based irregular crypt. And I would think if this is SSP, so I end up calling gastroenterologist, did you see a polyp? Because if you see a polyp, I would go with SSP. But if you didn't see any polyp, it could be a reactive chain or chronic prolapse type mucosal injury in polyp stalk. And this is it is biopsy from the polyp stalk because he saw irregular and thickened mucosa. Another thing is polyp nature. It could be heterogeneous or homogeneous. If you're lucky enough, you got diffuse high-grade dysplasia all over the place, and no matter where you biopsy, you get the same thing. But if polyp contain necrosis or low-grade intramucosal carcinoma, invasive or high-grade dysplasia, so you should do multiple biopsy enough to represent different area of the polyp. And this is one of the problems that commonly happen in everyday practice. This is an obviously malignant lesion for you, but it could be subtle for pathologists. When you see the dysplastic gland infiltrating in a hemorrhagic or inflamed lamina propria, and there is no muscularis mucosae, there's more plastic reaction. So I would go with superficial fragments of adenocarcinoma. That means I cannot tell you, I cannot distinguish between intramucosal carcinoma and true invasive, superficial portion of true invasive submucosal adenocarcinoma. And you can see this malignant polyp on the surface, there is only high-grade dysplasia. But if you got a deep bite enough into some mucosa, you can get the right answer. But it's not always possible to get that deep bite. Coming to the other factor that is very important is specimen handling. This is a very nice example case, but horrible. This patient came for surveillance colonoscopy. He had 5 polyps, 3 in the ascending colon and 2 in sigmoid colons. And all polyps were removed piecemeal, but submitted in the same container. I got 13 fragments of specimen, and 4 or 5 fragments are malignant polyp with positive margin, and the remaining fragments are adenoma with high-grade dysplasia. Then the question is, what are you going to do? Which segment of colon will you take out? Could it be more than one? You may guess the largest one could be a malignant polyp, but malignant polyp can occur in small polyp too. So would you do a subtotal colectomy or sigmoidectomy and wait and see? It's a tough question, so never ever submit the suspicious polyp in the same container from different segment of colons. Another issue in specimen handling is all you may know about shrinkage artifact, because GI has muscle and they have a great capacity to shrink. When you left tissue before fixation into formalin, it can shrink up to the median shrinkage happen in 3 centimeters. And when you put it into formalin, additional 1 or 2 centimeters can shrink. And if the margin is of your concern, so please mark. For pedunculated lesion, don't be overconfident that you have a pedunculated polyp with very nice long stalk, because it could become shortened in the degree that pathologists can no longer recognize it. So if pedunculated polyp, just mark the stalk margin first, and for flat lesion, the best method is to pin the specimen without overstretching and fix it in formalin immediately. This way will give you a best measurement of the margin distance and assess about tumor depth in the most accurate way. Another thing in specimen handling is just keep an eye on your assistant, because some of those will forget to put the specimen in formalin container, and sometimes they left tissue in room temperature, and at the end of the day they put it back to formalin. By that time the tissue will completely autolysis, and some may wrap the tissue in dry gauze or soap gauze or in saline solution, because they think it's a magic liquid, but saline solution in pathology is an enemy, because they don't have fixation effect, and they can put us a lot of hydrophic degeneration change. And this is an example of crash and thermal artifact. It happens every day, and pathologists hate thermal artifact and staple artifact very much. For bowel preparation artifact, we lost surface epithelium, and this for adenoma with bowel preparation artifact, we cannot evaluate surface maturation. And this is a tissue that has complete autolysis from poor fixation. You may put in the formalin that out of date, it become cloudy and lack of formalin smell. So the lack of fixative effect, and the tissue will completely wash out. And you may see here that there is no cytologic detail. And when compared to normal tissue over here, I cannot tell anymore. This is a low rectal mass, and this is definitely should be a cancer, but I cannot make a definitive diagnosis. So if you don't want to ask patient to re-biopsy because of this reason, just keep an eye on your assistant. And type of the procedure do affect the evaluation of polyp. In EMR specimen, when you inject saline solution underneath some mucosa, it could make the artificial broadening of the margin, and the margin may be wider than the actual distance. And for piecemeal removal, most of the time, I can do margin evaluation only in a large fragment with a marked suture material or ink margin. For the rest of the fragment, I cannot do margin evaluation anymore. And when it comes to malignant polyp, there's a time that you may want your pathologist to evaluate the degree of some mucosal invasion, like an Hackett and Kudo level. But in polypectomy specimen, we don't have the full thickness of submucosa like demonstrated in the picture. And in polypectomy specimen, if you see over here, there is cancer all over the place in submucosa, and we don't have any idea how much submucosal tissue left in the patient. So to grade 1/3, 2/3, or full thickness of mucosal invasion in polypectomy specimen is almost impossible. But you can ask, and I try to do my job, but not every time I can tell you. And we're done for the pre-analytical factor that affect evaluation of polyp. The rest will happen in the laboratory. For example, this is one of the cases that Dr. asked me to review. It's from outside institution. Patient has 2 polyp in rectum. The smaller one is malignant polyp. The larger one is advanced polyp, is tubulovillous adenoma with high grade. But unfortunately, a pathologist assistant did a wrong cutting of polyp head in this plane. In this fashion, you cannot do margin distance evaluation from carcinoma to stalk margin. The correct plane should be like this, and both polyp are cut in this way. And the initial pathology report come out like malignant polyp margin undeterminate. And so when I got all the block, I asked my technician to do a 90-degree turn block section. And you can see over here, the sharp edge represent the initial wrong cut section. The irregular edge is the final deep margin, and thankfully, the margin is still there in the block. And the final report come out like tumor approach margin in everywhere and LVI positive. And then Dr. Art has enough reason to take our rectum. And the wrong plane of section does not happen only when we do gross assessment. It also happens in the embedding step, that histologists must put the GI or colonic biopsy on one side in every fragment and put it at the right angle of the base mold to get the right orientation of GI layer. And it's not easy because you must do it real quick, and every single fragment must align in the same place, and then put it into paraffin box and cut it into a thin slice section. And this is an example of the case that where you get a wrong plane of section, that you cross-cut the colonic crypt, and it come out like the starfish shape, not a sawtooth. And in this way, I cannot see the crypt base, and I cannot distinguish between hyperplastic polyp and SSP, because SSP, you need acceleration all the way through from surface to crypt base, and you need a broad base crypt shape, like L shape, boot shape, or anchor shape, whatever you say. But I need to see the crypt base to distinguish between the SSP and hyperplastic polyp. And in bad plane of embedding, you can miss a minute adenoma, and the pathology report would come out like normal colonic mucosa, and you get upset because you see polyp under endoscopy. Other error that can happen in laboratory is processing error. It is a nightmare for pathologists, and I got it once when I have a new lab technician. She forgot to fill out the alcohol tank in tissue processor, and then the tissue above the alcohol level get under dehydrated, and it would come out like a very red tissue chatter and ground guard everywhere. And too thick section or overstaining of section can make the normal colonic mucosa look like adenomatous dysplasia. And the final thing that would affect the polyp evaluation is pathologists themselves. Regarding interpretation skill, pathologists look at the same thing and can overcall, undercall things. And for non-GI pathologists or general pathologists, they tend to overcall things rather than undercall things. And this is the nice case that the both cancer case in this picture, but I only see high-grade dysplasia with a nice layer of muscularis mucosae, no submucosal invasion, so I cannot go far beyond from high-grade dysplasia. Even your clinical is obviously malignant, but I cannot pull the trigger based on the histologic slide, so please correlate with clinical. And the last thing, that pseudo-invasion in polyp is always a problem, but if you're objective enough and strict to criteria, then there's not much case that we would miss. And in conclusion, every factor that happened before and inside laboratory can affect colorectal polyp evaluation. And endoscopic finding, nature polyp, sampling technique, and proper handling of specimen would strongly influence polyp evaluation. And standard growth assessment and quality tissue preparation are critical for pathologists to evaluate polyp pathology. And valid synoptic pathology report would help you to make a decision on patient care properly. That's all I have. Thank you.
Thank you, Dr. Mingkhwan Tippayawong. Thank you so much.